Register. Dear friends, welcome to the last one Hippocrates webinar on the STARS model on brain. In the previous 2 days, we had two really wonderful lessons from Pierre Gressens and Linda De Vries, with a total of about 800 participants and about 3,000 registered people. So I take this opportunity to thank Pierre, Linda, and Luca for their collaboration. And obviously, thanks also to today's speaker, Professor Neil Marlowe. And now I leave to Linda the great pleasure of introducing Professor Marlowe. Please, Linda.
Well, thank you very much, Professor Moretti. And as we mentioned also yesterday, it's a great honor and pleasure that we're allowed to do these modules for the UNPS for neonatal neurology. And I think they are being well received, and it's a pleasure to do it. And it's a real honor and privilege to today's speaker to introduce Neil Marlowe. And he is really a giant, and I could fill a whole 40 minutes to introduce him, but I will not do it. I've known Neil since the 80s, I think, and I first met him when he was still based in Bristol. And he already in those days was very interested in follow-up, and he was involved in the so-called AVEN project of preterm babies and having people coming at home to visit the preterm babies and see whether that would help in their development. He then moved to Nottingham, and then later, more recently, he was working in UCL and as a professor of neonatal medicine. And his major academic interest, of course, we all know him from the Epicure studies. And that has been really wonderful and has really been so important for everything we've learned about the preterm babies, how care has advanced over the years, and especially being able to follow these children for a very long period of time. And what is really interesting here as well, that every time when you listen to Neil, he always has a story to tell about the children as adults. And this also shows how dedicated he is to long-term follow-up. Well, finally, Neil was elected a fellow of the Academy of Medical Sciences in 2007, is an honorary life friend of Bliss, and he was also the first recipient of the Bliss Lifetime Achievement Award in 2019. So Neil, thank you very much for giving a talk, a presentation today, and we look forward to your lecture. Thank you.
Thank you very much. Today we're going to talk about adult outcomes after extremely preterm birth and to look at the extent to which we can implicate neonatal brain injury in some of these outcomes. At the outset, I have to apologise to those of you who attended our webinar, but unfortunately the Wi-Fi in the hotel I was staying in was not suitable for the task, and so I agreed to record this subsequently. Preterm birth, particularly extremely and very preterm birth, is the end result of something that has gone wrong in pregnancy. A whole series of antenatal factors conspire to provoke the delivery, be it growth restriction or be it infection or other influences. And subsequently, the effect on the baby, both in terms of the brain and indeed of the other tissues in the body, is that we have a whole series of complex, injurious problems and also developmental changes. Today, we're going to concentrate on these core executive, low IQ and behavioural problems as the major areas. But one needs to remember that to the adult surviving very preterm infants, problems of lung function, problems of hypertension and other organ function may be just as important as they grow up. Joe Volpe, in his Lancet paper, published this beautiful diagram showing that preterm brain injury is a very complex affair. And we know quite a lot about the large hemorrhagic lesions that we find in germinal matrix, intraventricular hemorrhages, and in the periventricular hemorrhagic infarctions we see that are frequently associated with cerebral palsy and motor problems. However, they are also associated with low IQ and other neurocognitive outcomes, as are problems where we have periventricular leukomalacia, be it diffuse or focal, and also non-cystic changes, which we are beginning to recognise. Professor Volpe described this as a complex amalgam of developmental and destructive disturbances, which really is where we're going with this talk. Prematurity is also a continuum. And so if we take this graph here, which shows the prevalence of special needs by gestational age, against a log scale, we see that there's an almost exponential rise in the prevalence of special needs as gestation reduces, such that between 28 weeks of gestation and 24 weeks of gestation, we see a doubling of the risk. So what we're going to do now is to explore the range of neurocognitive outcomes that we've identified in early adult life following extremely preterm birth, and to consider the neonatal influences on those outcomes, and to look at the extent and potential consequences of neonatal brain injury, and some intriguing new data as to how that might then be ameliorated. The first thing to say is that many studies have done associative studies. Very few have done formal prognostic studies. And in this systematic review that was done by Llewellyn Sell, a statistician from the MPU at Oxford who was working with us on this, she identified relatively few publications where you could actually say this was a proper prognostic study. This paper is twinned with another paper in American Journal of Epidemiology, which sets out the criteria needed for a prognostic study. And when we look at this, we see that these variables here were significant in the final model. And of course, the one that's found most frequently is brain abnormality or injury. Associated with this, when we look at cognition, we find that the parental factors, and here we've used lower level of parental education as our prognostic factor, lower gestational age as we saw on the previous slide, and then a whole range of other factors, of which I'd draw your attention to bronchopulmonary dysplasia as one that may be important. The other thing to note is that there's relatively few, these shaded bars here, that have low to moderate risk of bias in those conclusions, and only one that had a large sample size, which would allow a more accurate establishment of prognosis. So, over the last 15 years, we've seen two developments that have really made a huge difference to what we can do. The first is the Adult Born Preterm International Collaboration, which was set up by EUROPEA and Segal about 15 years ago now, where they brought together all those studies that were working in longitudinal studies of adult outcomes. And we started to think about how we might put some of those studies together and what new studies were required. Then more recently, the RECAP Preterm initiative was established. This is funded by the EU, and it is an important new development because the RECAP Europe study actually brings together individual patient data from a whole range of other studies, which allows us to explore individual patient meta-analyses in a way that we haven't been able to do before. And as the database has been set up, this can be interrogated by individuals after discussion and permissions from the data owners. So we can bring studies together within the RECAP environment, obviating the need for us to have data collaboration agreements with each of the studies, which can delay studies by 6 months to a year. One of the first studies that came out of this was a study where we looked at cognitive impairment. And Robert Eves was the first author on this. And what this analysis shows is that the IPD data that we have at the top here was analysed separately to the aggregate data that we have from other studies. And you can see that the two methods are not that dissimilar. The first IPD studies are arranged in descending order of standardized mean difference, which also approximates to the gestational age of the cohort, Epicure being the most immature of all the cohorts that were included in this IPD data. And you can see that when we do this, we find that very preterm birth or very low birth weight birth incurs a 0.8 standard deviation, which is about 8 to 9 points in IQ. And you can see that this ranges from around about 0.6 of a standardized mean difference down to well over 1 standard deviation discrepancy. Now, we've known this for some time. We know there is a continuum of cognitive outcomes. And we also know that the outcomes that we see amongst the extremely preterm individuals that we follow up the cognitive outcomes are much more complex than those of the term-born controls. Here we have the number of cognitive impairments on executive function testing that we measured in Epicure at 19, and you can see here that in the darker hatched bars here, you can see that the number of executive function impairments for some children was quite extensive, whereas for the term participants, most didn't have any impairment, and those that did had only 1 or 2 impairments in the main. And this is important because the complexity of what's happening to the brains of extremely preterm survivors is something that we do really need to get a handle on. If we go back to the Eves paper, he was able to take over 1,000 adults and do an individual level associate regression. And he did this at a 1-stage multivariable analysis. And you can see that gestational age is important, as we might expect, and the birth weight for gestation age is also important, as those who are small for gestational age or have suffered fetal growth restriction are also more likely to have intellectual problems as they grow up. But we see that there are 3 other significant findings here. The first being maternal educational level, as we might expect. And the second is perhaps not expected, and that is the presence of neonatal BPD, which was significantly associated with poor cognitive scores. And then finally, neonatal brain injury. Now, remember that, of course, neonatal brain injury in 95 and before that, when these studies were originally done, was a relatively crude measure, and we might be able to make better measures of those factors in 2022. We also looked at how these factors might progress over childhood and into adult life, and as part of the Epicure assessments, we looked using multi-level modelling at the stability of IQ across childhood. These are the term controls we picked up at 6 and saw at 11 and 19. And here are the extremely preterm groups who had IQs measured at 6, 11 and 19 and a Bailey 2 assessment done at 2.5 years. And you can see that the gap between the 2 cohorts remains fairly consistent over childhood, and these 2 slopes are not significantly different. We can also look at the fact of the influences that were on these outcomes, and here we see maternal education. The solid bars are those with longer maternal education, those with lower educational attainment. And you can see that the effect of maternal education persists over childhood and is a small effect compared to the effect of prematurity in this population. We can then look within the preterm population itself, and here we've divided it by gestational age of 25 weeks and those below 25 weeks. And you can see that the the lower gestational age is associated with lower cognitive scores. And again, these remain fairly constant over childhood. And then if we look at neonatal brain injury, we see the same findings, except that, of course, this is simply just IVH and neonatal ultrasound that we're looking at here, and it's not a very sophisticated way of looking at brain injury. The other major group of outcomes that people are concerned about are those of psychological performance or psychiatric problems. And Peter Anderson has used these collaborations to look at an individual patient data meta-analysis of psychiatric disorders. And there are no great surprises here in that the presence of ADHD, particularly in the inattentive or combined types, autism spectrum disorders, anxiety and mood disorders are all significantly associated with very preterm or very low birth weight birth. The pattern of these outcomes is a particular pattern that we see frequently amongst preterm children, and relates to the presence of inattention, anxiety and social difficulties, often in association with low IQ. And what we don't see in this group are disruptive or oppositional defiant disorder increases, problems in eating disorders or psychotic disorders. This is a reassurance because many of us were concerned that we might see schizophrenia amongst this group, but that doesn't appear to be borne out. Although, as a word of caution, most psychotic disorders have become most apparent in the third to fourth decade, and many of these populations have not reached that. We also know that this phenotype is fairly consistent across childhood, and if we go back to longitudinal multi-level models, we see that these are the total difficulties scores on the Strength and Difficulties questionnaire, stratified by the child's behaviour at 2.5. And you can see again there is a remarkable stability. Those that have poor behaviour, which in the red at the top, tend to remain fairly constant across childhood. And if we look at this and stratify it by cognitive impairment, you see it is mainly those that have moderate to severe behavioural problems, moderate severe cognitive impairment that have the behavioural problems. The problem is that these data have rarely been looked at in terms of associative findings, and few have evaluated prognostic factors. When we tried to do a systematic review on this, we couldn't really find very many. And it's mainly, the associates are mainly poor cognitive scores and socioeconomic markers. Several studies claim differences between the sexes, with boys having worse behaviour than girls, but actually these findings are relatively inconclusive across those papers. The thing that is causing people much interest at the moment is the presence of autism in this population. And we have seen a fairly consistent prevalence of autism over the childhood studies that we've done into adult life. At 19, we were able to use the state-of-the-art broad autism phenotype assessment, and you can see that scores in terms of aloofness, rigidity, pragmatism actually are elevated in the extremely preterm group, indicating more autistic features. And this is mirrored in the total score. We also see a reduced facial affect score and reduced empathy quotients, which actually fit together that this is more of a social communication problem than classical autism as such. But overall, individuals reached a clinical score for autism in about 9% of cases. And this correlates at 19 years with what we measured at 11 years in terms of using the social communication questionnaire. And again, is very much related to low IQ. And I think that is important. So what can we say about brain injury in this group? We can say that it's a major risk factor in neurological and cognitive outcomes, as is BPD for that matter. Low IQ and poor executive function are consistent features, and the effects are seen right the way across childhood and adolescence. There are relatively fewer studies of behavioural outcomes, but those that have imply that low IQ, which of course is related to brain injury, is a major feature in terms of the development of behavioural problems. Now, these data are actually quite difficult to interpret. The most obvious problem we have is attrition. And we might have selective recruitment of those with better outcomes. And also those who have the worst neonatal brain injury may have worse outcomes, and these we know are likely to default. We also know that the social economic status is related to the prevalence of both low IQ and behavioural problems. And we know that in those where there's social disadvantage, attrition is much worse. We've tried to overcome this using multi-level modelling, but at best we can say that the data I've shown you are likely to be a best case scenario. And we still worry a little bit about the definition of brain injury in these studies, because it is made on what were, at the time, relatively crude ultrasound assessments. Can we do better if we think about the correlates between brain and behaviour as adults? Because this might give us a clue as to what's going on. Well, nothing is easy, and it certainly is quite complex. People have studied brain behaviour correlates using structural MRI, using whole brain region of interest studies, and have looked at it longitudinally. They've used microstructure during a diffusion-weighted MRI, and they've used fMRI to look at both intrinsic and task-based functional networks. One of the great difficulties about looking at these data is that relatively simple psychological tasks, such as working memory or short-term memory, in the two examples shown here from Epicure at 19, actually affect widespread areas of the brain. Those that are shown in colour here of the segmented brain. And so actually finding specific injuries related to specific outcomes is unlikely to be a very productive series of investigations. People have, however, looked at a whole series of structural correlates. Hippocampus, for example, has been associated with memory. The size of the forebrain has been linked to IQ. And there's a range of areas associated with both low IQ and executive functions. In terms of white matter, we know that callosal volumes are related very much to poor executive function and IQ. And we can see various regional changes in white matter development, which are also linked to these tasks. The problem is that these structural correlates, and I refer you to a lovely review by Hideo and Nazati here, these structural correlates are not really telling us anything other than there is a simple association between these regions and these measures. Other people have looked at tractography. Here we've got working memory scores and cognitive flexibility in this study from Trondheim, and we can see here that there are areas of white matter tracts that are associated with these outcomes. And that, of course, is interesting because it implies that the development of these association bundles actually is disturbed in this population. The Trondheim group have also done fairly regular MRIs on these children and looked at changes over late adolescence. And if we take the control population, we see that there are various areas that over the 5 years between 15 and 19, we have quite a lot of thinning in several areas over the cortex, from occipital to frontal and parietal lobes. However, when we do the same analysis for preterms, we see much broader thinning. This may well be an important difference that has started to occur during adolescence between preterms and term-born individuals, which may have implications for later life. We know that the degree of thinning relates to executive processes. Here we've got a global executive function measure, which is expressed as a Z-score. 0 to 4, -2 standard deviations, -4 standard, -6 standard deviations. And you can see here the changes in the left temporal pole, which is one of the areas most affected by this thinning, in the occipitotemporal gyrus, and also in the superior parietal lobe, just as examples of how different the behaviour of these areas in the very preterm and the controls are. We also know that the findings that we have in infancy tend to persist over adolescence, and they tend to be independent of those disabilities that we see. The New Zealand cohort has followed individuals through to 28 years now, and finds that actually most of the modalities all agree that there's a particular temporal lobe vulnerability in this population, which actually is related to your maturity and may be a reflection of the changes we see in IQ with prematurity. And we also have seen quite a lot of surface area decrements from the Trondheim study, which also might imply that these are related to developmental changes that have happened in the brain and persist through to adult life. Well, this is quite a challenge, because trying to tease all this out is to my mind, very difficult. And we need new ways of thinking about it. And one study that has started to look at this in a very different way, and I think is quite unique, is a study from the group at King's and St Thomas's, the Centre for the Developing Brain. They've been following a large group of very preterm infants from their E-Prime study and also from the Human Connectome project. They have evaluated outcomes in 384 very preterm infants at 4 to 7 years and correlated those with the neonatal resting state analysis. Now, the problem with doing long-term studies is you measure many things. These are the IQ scores from the WIPSI, there is executive function, there's social responsiveness, there's attention deficit disorder, there's general behaviour, there's empathy quotients, looking at social cognition, and other measures. And how we put those together is quite a challenge. So what this group did was to put these into a principal component analysis. And from this, they derive 3 principal components, which are shown here under A. And you can see that these 3 groups, PC1, the first component, was the preterm behavioural phenotype. And you can see there was some association with IQ, but also with executive processing, and mainly around behaviour and social responsiveness. The second component comprised mainly of cognitive items, and the third component was described as socio-emotional outcomes. You can see that actually if you look at the correlations between these components, they are extensive, but actually being able to isolate these 3 components gives us a way of looking at the data which is statistically reliable and also likely to be very interesting. In addition to these measures, they also ask parents to complete a questionnaire derived from the home inventory, looking at the environment with respect to cognitive learning. And they defined a cognitive stimulating parenting scale. This scale is quite interesting because when you look at it, it's negatively related to the behavioural symptoms within the PC1 principal component. And so it would appear that your parenting actually is directly related, and the style of parenting is directly related to the behavioural scores that we're actually seeing. And I think that is quite interesting because it starts to tell us that actually there are some things that we might be able to do something about. In contrast, if we look at the cognitive scores, these are related to higher volumes in one of the resting state networks, the salience network, which is highly associated with general intelligence. And you can see that perhaps the cognitive scores are more related to how the brain has developed than necessarily the behavioural phenotype that we're actually looking at. So, it is clear there are relationships between altered brain structures in preterm young adults and their outcomes. We know there are multi-region correlates that make that assessment very difficult, and the basis in individuals is actually quite unclear as we look at it. Computational MRI and large populations are needed for this, and I've shown you an example from the Human Connectome project, which I think is a really interesting and potential way forward. We also don't know what happens to cognitive performance as the child ages. And we know that there may be some changes in the psychiatric phenotype as we go from the third to the fourth decade. But we also know that cognitive ability does tend to decline with age. And whether this is more marked or accelerated in the preterm population remains to be seen. At the moment, there's little evidence that that is the case. But we need to follow it through to understand it, because it would give us a handle on the changes that we see in middle age and their relevance to neonatal brain injuries. Behavioural outcomes are actually fairly rarely studied as adults in preterm populations, so we need to get a good handle on these. And these new childhood studies might be providing us some explanation as to why they are differentially related to neonatal events. Now, we've talked a little bit about cognition, executive process, and psychiatric outcomes, but this is the whole range of outcomes that we might see in adult life. And the societal outcomes, both the quality of life, their ability to participate in society, and their ability to generate wealth, are actually equally important outcomes. And as I said before, the somatic outcomes may also be of great importance to these adults as they go forward. But the one thing that we haven't yet really bottomed out is biological aging. And we've got a couple of studies that are beginning to show that there may be difference in markers for aging in the very preterm population. But until we've got better studies of those, it's difficult to be absolutely sure as yet. So in conclusion, executive function and behavioural outcomes together with cognition track from middle childhood to adult life. Neonatal brain injury is an important prognostic factor for low IQ, although the associations with behaviour are more variable, though poorer behaviour scores are seen in those with low IQ. Brain development is a complex way and development after preterm birth is, again, in itself very unclear as to how those relationships go ahead. Adults, we know, show similar brain changes to those we've seen in the neonatal period, but adolescents may impose on preterm brains a rather different developmental track, which we need to follow further. There's some new data suggesting a causative dichotomy between cognitive and behavioural outcomes, and that leaves us with the conclusion that adult outcomes show pervasive effects of being born early. Having said that, the proportion of children that are affected in this poor outcome group is relatively small compared to the majority of children who grow into adult life without major problems associated to their preterm birth. And although we concentrate on the negative when we're looking at these populations, for most children who are born after very preterm, very low birth weight, or even extremely preterm birth, have a satisfactory outcome as adults. Thank you very much.